Welcome to another Clinical Tips with Dr. Jen Kim. I'm Dr. Jen Kim. I'm the board certified periodontist practicing in various locations in Southern California. Today I'm going to talk about this one challenging case. This gentleman had presented with fair teeth that were periodontally salvageable, but he had lost a number of teeth in the upper right, and he had attempted implant restoration in the upper left that didn't do very well. The remaining teeth were quite questionable, and although they may be saved in a certain way, he had a class 3 angles malocclusion, and in general, very weak and unsustainable teeth. So all kinds of treatment options were discussed, and ultimately the patient and I mutually agreed to a full arch rehabilitation with 6 implants with immediate loading protocol. What's commonly known as the all-on-X or all-on-6 in this case. This is the kind of the menu that we provide in our private practice, and we can go from bar over the denture bar, conus type over the denture to fixed locator, and so on, as you can see. And in this case, this all-on-6 type of an approach offered the best solution for this gentleman. One, because of the immediacy, and the other because we could solve his class 3 malocclusion, which was a source of etiology for breakdown, namely trauma from occlusion. With great AP spread, this was going to afford a very good solution. Of course, in the lower, he was going to do fine, but it didn't matter. But I'm just sharing, what our treatment protocol is. And here's an example of an all-on-6 in the mandible in a different patient. Well, all-on-X's or immediate full arch protocol are not always successful. Case selection is extremely important, and here's a series of problems as to why the case might fail, and this is from one of my lecture slides. And one of the key things is the AP spread, and also in this case it's a true all-on-4, which I believe in the maxilla does not have a great track record. I always do 5 or 6, and 6 is my go-to. So as you can see here, the AP spread, anterior and posterior spread, is what determines the ultimate physical stability. And only when you have 6 implants with utilizing the pterygoids to get the most posterior anchorage, and perhaps zygomatic for a number of reasons, are a good strategy to gain an all-on-6. This is a case that was treatment planned together with Rowe Dental Lab using the Chrome Guided Smile protocol. And as you can see here, a number of stackable surgical guides that are made to fit like a glove on the degloved maxilla, and we have stereolithic 3D printed models together with 3D printed metal guides, and we'll walk through how this case was completed. This is a preview software, simulation software, that a patient had seen, and he had liked it and approved it. In fact, it was critical in the decision process for this case acceptance. Here is the class 3 skeletal profile. The mandibular teeth needed some periodontal therapy, but the maxillary teeth and remaining 2 implants were quite problematic. Here are the 2, ironically, zirconia implants placed in a very odd angle, and some restorative issues. The advantage of having zirconia implants is because of the biocompatibility of strengths, cosmetic value, and whatnot. But as you can see, the emergence profile and the gap truly is an issue. And even if it's placed absolutely correctly, it's very hard to get the nice soft tissue profile. In this case, it was nothing falling short of a disaster. So the upper teeth were all removed, and here on the bottom we see how the bone reduction guide was utilized so that we can have the right plane of reference, and ultimately that's how we were going to get the teeth aligned. So that previous line of bone reduction represents where the red line is in this pre-surgical workup. So here are the 6 implants, 2 pterygoids, 2 zygomatic, and 2 in the anterior zone, the sort of routine 15 millimeter implants. And area by area, we're going in a sort of a clockwise direction. This is the pterygoid in the upper right. This is the zygomatic in the right side. The anterior one, relatively straightforward after the extraction. The other anterior in the contralateral side, the zygomatic in the left side, and the pterygoid in the patient's left, using the osteotome as a pilot to verify that we are spot on at the target. So here we see the bone reduction extractions followed by implant placement. The abutment were securely tightened, and now the prefabricated teeth, verifying that the midline is correct and the cant and the overall vertical was correct. So the conversion happened as was planned, and we can see the conversion appliance with very secure AP spread with 6 implants with great stability. Soft tissue handling can be somewhat of a challenge, and I always try to utilize the excessive palatal tissue that can be used to increase the zone of keratinized tissue on the facial, but also to increase the vestibular depths, and try to get as much attached keratinized tissue, especially around the pterygoids and around the zygomatics that tend to, from time to time, buttress out into the facial vestibule. Here is how everything was put together. The cleansable conversion appliance is now bolted back into the mouth, and here is the occlusal view. This is a pre-surgical assessment using the so-called venous gauge, and it coincided with the vertical, so I was very happy that we were reproducing exactly the pre-planned procedure. The patient was sedated, in fact intubated, so at this point immediately post-surgical, the patient was not able to express very well, but the midline and the amount of the tooth display seems to be quite adequate. And this is 7 days following the surgery. We can see the soft tissue starting to heal. And here's the exciting part, the CBCT assessment. Fairly accurate placement of all 6 implants. Every one of them were secured to the point where we had insertion torque of no less than 50 newtons for every single one of them. The 2 anterior ones were probably way higher than that. And this is actually a short video that outlines individual cross sections. Here is the anterior, the right zygoma with good anchorage. As you can see in the cross-sectional view at the bottom quadrant. Here is the right pterygoid in pretty decent position. Here is the zygoma on the left. It was placed slightly more anterior than it was planned, but it was adequate for stability. And the right zygoma in a slightly different view of the CBCT. I'm trying to look at different slices to verify that the implant position is indeed stable and within the planned sites. Every one of them were, as I said, very stable, quite a satisfactory outcome for both the patient and for the clinician and our team, of course. So let's now move to the next slide. This is another video. We do use 3D facial scans for planning purposes, but it's also a very good verification tool at the end of the therapy, because it does afford that the lip support and the facial profile is exactly the way it was pre-planned. So here is the before and the after of the patient's facial view. Again, the patient was quite happy with the outcome. And I look forward to providing some of the follow-up radiographs and the result on another video at some time. Please like us and subscribe to my YouTube channel. Thank you very much for watching. This has been Dr. Jen Kim, the periodontist with practices in Southern California. Thank you.